Good morning, everyone. This is Leanne, and this is From the Heart. And today I have an episode that's been on my heart for a long time, and I've kind of sprinkled some information everywhere throughout my podcast, and it is about induction. So if you have been listening, this is just a reminder. I've had a lot of issues with how we reference the ARRIVE trial to our clients today, because what has happened in that randomized control trial is not what happens in the real world population. So the ARRIVE trial showed that if women get induced, first-time moms get induced around 39 weeks of gestation, which is about a few days before your due date, that the risk of C-section decreases for those women. So there are lots of biases, and that trial has gotten a lot of fame, and it's still being referenced today. It's not applicable to the population. So first of all, this is a randomized control trial where the environment that people were set up in was different than what we do in the hospital here. Women were given more time. A lot of women bowed out from this study because they did not want to be induced, which is actually a really common theme in the studies that I was looking at over the last few weeks, that women have a mega preference to not be induced. Of course, that makes sense because what we see and what women feel is that, there's more pain, labor is longer, they're admitted for much longer, there's increased intervention, et cetera, et cetera. So it makes sense. And there are women who do want to be induced, but that's more of a minority than the people who prefer to not be induced. So there's already one good bias right there, is that we're inducing a certain population. Then the other thing is that this trial was funded by Pfizer, I believe Merck, and another company. I know that Pfizer makes prostaglandin gels. So this is a medication for induction. Merck is another pharmaceutical company. And then the other company, I don't remember, but it's medical in some way. I don't think that it's pharmaceutical company itself. Anyways, that's just from memory. I did not review the ARRIVE trial. I did talk about the ARRIVE trial in some other episodes. I believe the one on research, which is like a long time ago, like 2 years ago. So there's that. And the other thing is now we're inducing a lot of women for these precautionary reasons. They're not medical reasons, they're precautionary reasons. And Hensi Goer calls them precautionary rather than an illness, right? So if you're inducing a woman because she has hypertension or preeclampsia, you are inducing her for her illness, for her morbidity has started due to the pregnancy. So that would not be precautionary, that would be a medical indication. But when we are inducing healthy women who are, so they don't have an illness, that's what a healthy woman is. If she is older, 40 years older, some studies, some countries say 35. In Canada, we use the age of 40 as advanced maternal age. We are inducing women who have a higher BMI than 40 when they first come into care. We are inducing, I saw some other indications like, in vitro fertilization, race, socioeconomic background, that kind of thing. So those women don't necessarily have illnesses. They're being induced for what we call precautionary reasons. So there's a really big difference there. And I was talking about risk factors being low risk, moderate risk, and high risk, I believe in the last episode. And so people will say high risk for C-section, but there's also high risk for illness. So high risk for C-section would mean maybe you're a little bit more high risk for if your baby is breech and you're wanting a vaginal breech. But that doesn't mean that you can't have a midwife. That doesn't mean that you can't go into labor. That doesn't mean that you can't eat in labor, that kind of thing, right? So it does mean that there's an increased risk. Depending on your care provider, that risk will depend on their comfort level with breech. And so ask them, how many births have they attended? How many of them have turned into C-section? And how many of them have turned into vaginal breech births that were planned? So, that's just an example. So actually, I was thinking back to like the things I said before in like earlier episodes, and then I was talking to a doula, and she was talking about the adaptation to having a baby and how after a really big change in life, that we are our emotions kind of, there's an adjustment period where we feel emotionally like a bit lower. And she says for 18 months. And it makes sense, having a baby is a really big deal. That doesn't mean that you're not going to be happy after your baby. I know there's a lot of, people kind of saying lots of things like you're never going to have sex again and your marriage is blah, blah, blah. Like there's also a really huge strength that comes from becoming a mother. And yes, there's a huge adjustment and things are going to change. You're going to have to communicate differently with your partner. But this is like just something to step into if you choose to become a parent, and it's a choice that you've made. Usually, most people know that they're pregnant in early pregnancy. Some people figure out later, maybe it doesn't feel like a choice for some people, but for most people, it is a choice. And so it's just something that it's just for growth. It's to become something different. It's to see what you are capable of doing. And it could be extraordinary, and seeing the growth in a woman and how she uses her voice and who she becomes after she becomes a mom can be really incredible. And there will be challenges, and those will change, as your baby grows and your baby starts having their own little personality and becomes you. It becomes a reflection of you more and more as they grow out of babyhood. So okay, where was I going? Yeah, there's a transition where there's an adaptation, and it could be an emotional one. And then she also said that when you leave a job, it can be the same thing. And I'm like, oh my gosh. And it's been not quite 2 years since I left midwifery. But like, speaking of like the reasons and the heartache that leaving midwifery has done for me, has really helped me. So like right now, I want to continue doing this. I want people to understand what's happening in the healthcare system and what we are doing to people and what we are doing to the workers. So, I was just thinking about like our culture for money, and there is like we're really seeing this like never enough money. It's part of our culture. We can blame the finger, we can like point the finger at like big pharma all we want, but basically we are all part of this culture. We all do it in some capacity. We're forcing ourselves to do jobs that we don't want to do. There are companies that have nothing to do with the medical realm, where it's all about how do we make more money, rather than what can I do for the person who's going to buy, what would be the best thing for them. And there are people who do their businesses that way. And so I think it's really important to expand ourselves in people who are really trying to help the customer or the patient, the person that comes for our services, so that we can kind of step out of this like never enough mentality. Because when we work in a way where there's never enough, we're never going to be happy at our job. And when we follow our hearts, it's like it kind of like this thing of never enough kind of dissipates. Like good deals come in, people want to take care of you. And so like I had to struggle financially as well. And it feels good. It feels good it finally feels good to kind of like make that note. And I'm not working for not enough money right now. And that feels so good. Anyhow, so that's like a cultural change that if we wanted to do, and we want to, point the finger, if we need to point the finger at Big Pharma or whatever it is, I think that we also need to realize that the finger points at us as well. So I was talking to this about like a client of mine, and because she lives near me, we see each other frequently, and she just came to me and she was like, I see the same thing in my dental hygienist work, where she sees dentists calling out these cavities that they have to fix at a point where it may not need to be ever fixed. So she was explaining to me that there are 3 layers to our teeth, and that you can have a cavity at the first level that never changes, especially if you take good care of your teeth. And then she says that, yeah, it is like there is a need to fill the cavity, to take care of the cavity when it's in the second layer, but you may not need it at the first level of the enamel. So anyhow, this is just like talk between us. I'm not a dentist expert, but just something that she was telling me. I did not review the research on this, okay? So today, what I did is review the research on induction, and I will have to say that there is a lot of good people out there who are trying to make a point that the amount of intervention that we are doing now to clients, that the outcomes that we are seeing on our population, a lot of people are not happy about it. And when we look at it worldwide, it feels like it's a lot of people. I will say that there's a lot of fear, not just instilled in the client, but also instilled in the healthcare provider. And so, like this constant fight in the hospital or with our colleagues in clinic and that kind of thing can also impede the informed choice discussion that we have with our clients. And there's a lot of things at stake here, and things that trickle down. And because I'm like tired of this constant fight with explaining research to people, I've done my part. I have done that. I have explained to people, skin to skin things, things about choice, things about delayed cord clamping, brought up a lot of data. There's also things I just didn't have the time to do when I was working plus full time as a midwife. And so now I have the time, I can sleep, which is just a bonus. Client care, I could just eat up, I could just do more of it, but the political aspect of midwifery brings a lot of challenges if you care about the outcomes of the client, and the ability for other healthcare providers to inform women in a way that is real, that is not based on the fear that we are instilling on ourselves and other people, on our clients. So, okay, so I just want to say that I'm going to be speaking about data around stillbirth and neonatal mortality. You guys know that I already do that. And some references, to the episode that I did on the recent increase in maternal mortality. And so this is becoming like a big deal now, because we are actually seeing the outcomes of what we are doing now. So that's not something that weighs just a little bit on my heart. It's something that weighs really heavily on my heart, and so I will speak about it. If you are looking for something that is specific to just like, it's written just for the client, I found Sarah Wickham. I have not spoken to her or anything, but her blog is really great, and I actually bought her book. It's called In Your Own Time, where she speaks about the research that is done on different reasons and new indications for induction. And she goes into different research, not just the medical research, which can be very biased in one way of looking at people and just a certain kind of data that we are looking at. Like, if you just want to do one study and see if it decreases or increases stillbirth, we can do that, but we're only looking at one factor. And she really makes that point that there's a lot more than just the risk of stillbirth in outcomes that we are looking at when it comes to maternity care. she wants us to start looking at different sorts of research. She summarizes it so well. Actually, it felt so good to my heart to read her book. I didn't finish it yet, but I think that that's a really good resource for clients. If you are a midwife and you have your lending library for your clients, this is one to get. And I started reading some of her other books, the one on GBS and the one on, I forget which one, but it's intriguing, and it feels really good for the heart. She is a midwife who is also a researcher, and her information is really great and has helped open my eyes as well. And yeah, so basically, if you want to listen about data, I have some pages here. I'm going to try to make sense of what I say, because I am speaking to a screen, and that is not natural for me. I am meant, I'm a midwife in my heart, even though I don't pay for that title anymore, and I like looking into people's eyes and kind of responding to how someone is reacting in front of me with their eyes and their smiles and their facial expression and all that stuff, and what they have to say and their questions and their family dynamic and what's important to them. So I'm speaking to a computer that doesn't have any of these needs and doesn't have any of these reactions. So actually, I want to start off. Sarah Wickham actually quoted this, and it brings us back down to the feminine and all the things that we don't know. And research and data can only look at certain things. We can only calculate the things that are calculatable, So, and the things that we can think of, and we can't go beyond that. So, okay. So this is a quote by Lothian. She said this or wrote this in 2006. In the last weeks of pregnancy, maternal antibodies are passed to the baby, antibodies that will help fight infection in the first few days and weeks of life. The baby gains weight and strength, stores iron, develops more coordinated sucking and swallowing abilities. The lungs mature. He stores brown fat that will help him maintain body temperature in the first few days and weeks following birth. But the maturing baby and aging placenta trigger a prostaglandin increase that softens the cervix in readiness for effacement and dilatation. A rise in estrogen and a decrease in progesterone increase the uterine sensitivity to oxytocin. So oxytocin is what brings in the contractions. The baby moves down into the pelvis. Contractions in the last weeks may start the effacement and dilatation of the cervix. A burst of energy helps pregnant women make final preparations. It's the next thing that we talk about. Insomnia prepares them for the start of the round-the-clock parenting. The watchful waiting and the intense wanting of the big day to arrive are all part of nature's plan. When the baby uterus, placenta, and hormones are ready, labor will start. Additionally, all that preparation sets the stage for an easier labor and a fully mature baby who is physiologically stable and able to breastfeed well from the start. So I just also want to talk a little bit about some other studies. There's a study in 2004 that showed, we don't really know what starts labor. The science has not really kind of come up with that answer, but there is a study that showed that when the fetal lungs are ready for real life and breathing, there's a type of protein that is sent off, and so it sends a wave of prostaglandins through the mother's bodies, and like we just heard, so the prostaglandins get the cervix ready for labor. And the time where that happens is actually different for all women. It's not, 38 weeks, or it's not like, women are not robots, and women have we have to think like that, like, you know, like even like contractions when we say 411, a lot of women are not in active labor at 411 when contractions are 4 minutes apart, lasting an hour, la 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 la. So like women are not robots. This is just like, you know, rules where we're trying to capture things. And so like the thing with the gestational age as well is just another rule, and it's not like it's not specific to every client. It's not a 42 weeks for every woman. It's not a 38 weeks for every woman kind of thing. So just like, you know, every woman delivers spontaneously at a different gestational age. So, and then there's also a study that was published in 2013, that showed that the later a baby is born, so in the term period, when we're looking at 37 weeks onwards, the later the baby is born within that time frame, there is less likely to have breastfeeding problems. So if we group the women and the babies that are born at 39 weeks versus the women and the babies that are born at 41 weeks, there's going to be less breastfeeding problems at 41 weeks, 1 week after the due date. And the other thing that we say to women is that in France, apparently, never been to France, never done any births in France, but we say this to women is that the due date for first-time moms in France is apparently at 41 weeks. So instead of 40 weeks, we say 41 weeks because we do know that first-time moms especially deliver more on average around 41.0. And people who've had babies before apparently deliver more at 40 plus 3 days. So so there we go. Then I was looking a little bit over the studies that show that women in general have a preference to not be induced. It's not true for 100% of women, but it's true for a good chunk of women, and that there is less satisfaction for women who are induced. Women are more likely to have interventions when they're being induced, right? So drugs for pain, continuous electronic fetal monitoring. You can refer to my episode on that if you want to know the data about how we are listening to babies' heart rates in labor. There's more, intravenous drip, so like the little tube that goes inside your vein and gives medication or fluids through your vein. There are more vaginal examinations, right? When we are inducing a woman, she's admitted for longer. There's more chance of instrumental birth, caesarean section, and then complications from those things. You're more likely, so if you wanted to have a birth outside the hospital, you're more likely to have to move into the hospital if you're being induced and have to change your birth plan. Women who go into spontaneous labor are more likely to go home sooner. There's also an increased risk of postpartum hemorrhage for women who have an induction, and there's also more psychological trauma after an induction. Okay, so I know that I'm saying all these things. I'm not against induction. I am against the use of induction when there is no known benefit to the mother and the baby. And so I believe that intervention and the risk of intervention needs to outweigh the risk of no intervention. So we can't go choosing something that has more risk up here when there's less risk here so we need to wait until the risk is high enough for, let's say, waiting for spontaneous labor before we do this intervention that we do induction. Induction can mean lots of different things, lots of different ways of inducing. That's not what I went into the research for, but basically just to kind of sum it up is that your cervix has to be ready for induction before we start the contractions. And sometimes when we do the things that soften the cervix and open the cervix and that kind of thing, we can go into labor from that, which is a great thing. It means that we're not moving on to other interventions. But the reason why we do the softening of the cervix and all that stuff is to better prepare you for the things that are coming, so that we have your body is more ready, basically. So there is a timeline when you are admitted into the hospital, when we're starting induction and all that kind of thing, compared to if you go into spontaneous labor. Your early labor can last for a long time. You can be at home, you can rest in between, and all that kind of thing. And there isn't a timeline for early labor, but there is a timeline for your body being ready for the interventions that are coming. Yeah, so anyways, I hope I make sense. Like I said, I'm talking to a screen. Okay, so there is a study called CHOICE. And when we read through that, there's themes of lots of concerns from the client's point of view, and just less satisfaction. It can be a little sad to read through that. I will also say that I've had clients who were induced and they were happy to be induced, and it doesn't mean that you're going to have a bad perception of birth if you do get induced, but really, ask all your questions. What can I do to prepare myself better? So these are the things that I used to tell my clients when they were ready for an induction. We had made the decision together that she could be on the induction list, is that, to bring an eye mask for mom and partner, to bring earplugs, because there's lots of noise in the hospital, lots of like those emergency bells and other people running around in the hospital. So you want to bring earplugs, you want to bring flip-flops, you want to bring clothes that make you feel comfy, you want to bring your lip balm. You might want to bring like a nice soap that makes you feel like home, and like a pillow or two for both mom and partner, to make yourself feel a little bit more at home. You can close the door, you can get up and close the door to your room if you're given a private room. So in Canada, at least in Ottawa, you get a private room when you are in active labor. You don't need to pay extra for that. But sometimes women get put in a triage room where it's just a curtain until they are at that point in phase. So it's really important to bring that extra thing to make your sleep and rest a little bit better, and expect that your rest will be on and off, and like do all the tools, the meditations, the breathing techniques, whatever helps you in your regular life to bring you back to rest. Do those things wherever possible, even during the day if you can. I know that can be easier said than done, but trying is important. And even 15 minutes of extra sleep, extra rest can help when you're pushing, okay? Okay, so then there was a really great study by Dallin in 2021, and they were looking at the data in Australia, and then they followed up with the children that were born for 16 years. So that is uncommon, that we follow up with babies beyond a certain point. Like there's a lot of studies that will just follow up just for a few hours after birth and the admission to the NICU, and then that's it. And they followed up for 16 years. They were only looking at admission in the ER. So they didn't look at illnesses that were diagnosed with your GP and other things like that, but they were looking at that. So so a lot of the reasons why we get induced today is for the concern that we have for baby, A little less so for a mom, which is unfortunate. That's part of our culture. I am a huge, I will continue say that a healthy mom, if a woman is healthy and we focus on her being healthy, that, her baby is also more likely to be healthy. This is not just like it's not an incubator situation. This is a human, highly connected situation that goes beyond what science can see. And so, I want to say that. And okay, so what they saw with this 16-year I believe it's a retrospective study, which shows us all the retrospective studies that look at the data and what's happening today when we are inducing women for precautionary methods and all these new methods. Okay, I'm just gonna say it. It has not reduced the amount of stillbirth. And in the episode that I showed very recently, we are seeing an increase in maternal mortality. And I don't know the exact reason for that maternal mortality, but I'm very disappointed in how we are not speaking about it. And we need to look at what has happened very recently, because the change is recent. So are we dealing with the interventions that we were starting to do, in 2018 and 2020, and those kinds of things? And are we seeing now with the future pregnancies 2 years later, 3-4 years later, in 2022 and in 2023, we don't have the stats for 2024 yet. Are we seeing the outcomes on the reproductive life that has now, increased chances of all kinds of things? I don't know. Because the discussion is not happening, I can't tell you what is happening. I gave a lot of my questioning in that episode, but that's a mega one. That's one of the top reasons that I suspect could have increased morbidity and mortality in women. We have not seen a decrease in stillbirth at all. And the other thing is that we are wondering if it's actually increasing neonatal mortality, but I am not at that study yet in my notes, and so we're going to talk about that in a bit. So the study by Dallin showed that women with uncomplicated pregnancies that were induced had a higher rate of epidural and spinal anesthesia, had a higher rate of C-section. Like I said, the randomized controlled trials, they sometimes have a lower risk of C-section, but that is only in the environment setting that they have made for their clients and that specific population and how they have run their studies. It doesn't show up in the retrospective kind of data on our population. It has increased also instrumental birth, so that's when forceps and vacuum. It has increased episiotomy and postpartum hemorrhage. A postpartum hemorrhage is, after the baby is born, the placenta needs to be born, and with that, there's the placenta was attached to the wall of the uterus, and when that detaches, that's where blood can come from, because it's like a wound now. We can bleed before the placenta is born, and we can bleed after. There's a normal amount of bleeding. It looks very heavy, but then at a certain point, it needs to stop. If it doesn't stop, then we call it a hemorrhage. And then the definition for that is different for C-section versus vaginal birth. Okay, so and then when they were looking at the outcomes of the babies, they showed that those moms and those babies that were induced had higher odds of birth asphyxia, so that's a lack of oxygen at birth. They had a higher rate of birth trauma, so that would be kind of physical harm to the baby, which can sometimes also be minor, and babies can heal well from, but it can also mean trauma that sometimes some of the traumas are also not minor as well. Respiratory disorders, right? Major resuscitation at birth and hospitalization for infection. So that's the part where babies that were induced, and in the next 16 years, they saw an increase in hospitalization for infection. And this was not specific on the time that they were being induced, but just this is just specific to induction of labor in low-risk women, is what they go on to say. The other thing that the data is showing us is that over the last few decades, we have seen a really an increasing in the prevalence of labor induction. So, for example, this study here by, I can't pronounce it, Havalson, shows, so they were looking at data from 99 to 2019. They saw an increase from 7% to 25% of people that were being induced. So we're seeing this increased rate of induction. We're seeing an increased rate of intervention that comes from induction, and we're not seeing a decrease in stillbirth. And then the risk, the increase in intervention and the risk of morbidity that comes is the same as what I was saying before. And then they quote this, while reduction in stillbirth is a significant benefit if we see it, right? Other studies have shown that this may come at the cost of higher rates of neonatal mortality, including sudden infant death syndrome. We previously showed that an induction of labor for non-medical reasons, so these are the precautionary reasons like age and obesity and other things like that. So among low-risk women, so those are women that do not have illnesses, was associated with adverse health outcomes for both women and infant, compared with the women who went into, so compared to the same kind of women that you can compare them to that went into spontaneous labor. And then I went and looked at that in one of the studies that showed that there was an increased risk of SIDS, the sudden infant death syndrome, and they looked at 20 million births. Okay, so and then they looked at the women who were induced that were low risk at 39 weeks. And they were compared to women that were not induced that were of the same kind of population. Yeah, and there was an increased risk of perinatal death for those women. So these are not things that I used to say to my clients. I didn't know, okay? This information was not relayed to me. I need to go dig for weeks to find this information. And imagine a client who wants to have a real informed choice discussion and is putting a lot of respect and authority in me to give her information. I never said any of this stuff to my clients. So I really feel like I lied to my clients. I was not giving a very round, really like well-rounded information. I was just really saying the recommendation is for you to be induced because you are 40 years old, and the other recommendation is that you need more ultrasound when you're term. That's what I said. And then I said that we are trying to, the other things that I would say is that the risk of stillbirth for a woman, let's just compare women that are older, a woman who is 40 years of age or more compared to a woman who is less than 40, have the risk of stillbirth that are similar around, so for the woman who is 40 years old at 39 weeks compared to the woman who is less old and is 41 or 42 weeks pregnant. So there is no data that shows that the induction is what reduces the amount of stillbirth for those women. And the other thing is that we didn't actually remove the risk factors that can come. So yes, a woman who is, let's say 40 years old has more risk of hypertension, diabetes, and that kind of thing. But those are women who are already going to be induced for their hypertension or their diabetes. And so we're not removing those women out of the equation. So if we're we need to look at data where you're just inducing her for the age and not for the illnesses that has come and maybe she has a higher risk factor for. The same thing for obese women; they have a higher risk of obesity, diabetes and hypertension. But we are not extracting those women that have those things out of the population that we are studying, low risk versus low risk, and just looking at the differences within age. There are studies that they say that they controlled for those things, but what they actually controlled for was pre-existing hypertension and pre-existing diabetes. I am dissatisfied with the research and the data that we have right now that we are using to tell women that we need to induce them for certain reasons, precautionary reasons. Okay. So another study, let's see here. So induction, this is by Rydell, if I'm pronouncing it. I'm gonna, this is all gonna be in my show notes. So it showed that induction before post-term. So before you are, post-term is 42 weeks after birth, after your due date. I've been speaking for a while. My words might be super mixed up. So induction before post-term on low-risk women that are healthy without an illness was associated with an increase of caesarean section, chorioamnionitis. So this is important because part of the induction process is to break your waters, and we are breaking the waters before there are regular contractions, oftentimes, not all the time. And so the longer that the water has been broken for with vaginal exams, the higher the risk is for having an infection of the membrane that surrounds your baby. So that's what chorioamnionitis is. So there was an increase in that. There's also an increase in labor dystocia. Labor dystocia is when labor stops progressing. So whether you're in the first stage of labor when there's dilatation, or the second stage of labor when there is pushing. So there could be labor, like a stop in progress in those points of labor. It can also increase precipitate labor, which means a really fast birth. So some people see that as a risk factor and some other people don't see it as a risk factor. And then the mega really important one is that there's an increased risk of uterine rupture. That uterine rupture is actually, so like it's a really rare thing, but it's a very life threatening one. Okay, so uterine rupture would mean that at some point there is the uterine wall breaks, which includes the cervix as well. And then because you're pregnant, there's so much blood flow to get to the baby so that your baby can grow well, that if that breaks, if the uterine wall breaks, there's like so much blood loss. Okay, so very, very rare. Okay, but it's increased according to this study when it's looking at inductions of labor on low-risk women. So it's a really important one. They did show that there was, for women who were induced for without a medical reason, there was a decreased risk of oligohydramnios, which is when there is less fluid around the baby, which is also an indication for an induction. But I'll get to that later because I have questions around that. And then there was also a reduction in meconium-stained amniotic fluid. So that is when your baby is mature enough to just have a poop inside your belly because, they're mature. They have reached the age where they can poop. And the research around that kind of shows us that there's no need to worry too much about meconium-stained amniotic fluid for the general population. And there are some very not good quality evidence that shows that meconium stained amniotic fluid, especially when it's thick meconium, is associated with abnormal fetal heart rate. It's an association, and the studies are not of great quality, and they're really old. So it's when I would tell a woman that her water has broken and that her baby has pooped in it, I wouldn't make a big deal out of it. It's just, that's what it is. And your term, great, your baby is ready to poop. Okay, so okay, then there are other lots of other studies that kind of repeat what I have been saying. So I'm not going to go through these. Yeah, it keeps saying the same thing over and over, that the amount of induction that we have done over time has increased, and we're not seeing a decrease in stillbirth, and that we are seeing an increase in intervention and morbidity from those interventions. So let me find something that is different. Okay, this was by Coates and al., a study that came out that was published in 2020, and I found this fascinating. So it shows that there is evidence for induction for post-term pregnancies, not so much at 41 weeks, but more so at 42 weeks. Okay, there is also evidence for induction for hypertension and preeclampsia, so those two reasons improve maternal outcomes. And then there was some weak evidence for inducing women whose waters were broken at term. And then all other indications had either conflicting findings or insufficient power to provide definitive evidence. So this is actually really interesting because, like, you know, sometimes we can't do research because it's not ethical to do that study. So like because my brain is clinical and I've been, you know, inducing women for different reasons over the last 2 decades, then like I'm like, oh, so what about the very small babies? You know, like I'm not talking about SGA, like the small for gestational age babies. I'm like thinking the IUGR babies, like the intrauterine growth restricted babies. So I have questions around that. Where's the evidence? Is it not ethical to do that study? Which could be so. And then the other one was oligohydramnios, when the amount of fluid around the baby is lower, because we consider that a factor where the baby is potentially not getting the nutrients that it needs to from the placenta. So that's what we say. Is it evidence-based? You know, I'm like, I have questions around here, like what is helping? What so those are things that maybe there's a good reason for an induction. And I don't know. We're lacking some evidence there. Okay. And there the other thing that I saw, so when I was working I saw, so that I did see that there was more, there was the induction list was much longer. It was a lot harder to get women into the hospital for their induction. It was something that we had to manage. And the there was more inductions on the board where we saw, the reason, like what was happening into the different rooms, that kind of thing. The one thing that I actually saw increase, and this is like, I'm not a study, this is just something that I've observed myself, is that there was an increase in cord prolapse, because just like I was saying, there's more women that are being, their waters are being broken artificially. And if you're not in good labor, you're less likely to have a baby that's well applied to your cervix and into your pelvis. And so when we're breaking waters where the baby is not well applied in the pelvis, there's actually room for the cord to come down the baby's head and actually be squished by the baby's head. And then, so this is actually, so the cord is how the oxygen and all the other nutrients get to the baby. And so this is an emergency that we don't see very frequently, but has a really high rate of morbidity and mortality, like a really high rate of mortality. So so it's something that we need to discuss with women, and we also need to look at the data. Is that increasing? So that's just something that I have a really big question about, and are we looking at it? There was another study. They actually looked at more of there was another study that shows that uterine hyperstimulation is increased. So if you go back to the last episode that I did on the listening to the baby's heart rate, we know that what is associated the most with birth asphyxia is having too many contractions, and the cause of having too many contractions is by getting induced, so with the prostaglandins and oxytocin. Okay, so those are risk factors that, like, we actually do talk to women about that risk, so that's good. It's a part of the discussion. And then some other risks here that, oh my gosh, I went through so much. There's more risks that I have not discussed. And then, okay, then I talk about C-section. We don't need to go through that. We know that there's more risk with C-section, and then those risks are not just for that birth, but they are forever for the reproductive life of that woman, including when she won't be having babies later on in life. Okay, so let's see here. There's a study that, okay, so, no. I'm trying to find a study that is specific, but I can't, anyways, it's ideas in my head. Let me just kind of remind myself what it was. The Ontario Association of Midwives kind of went through a little bit of what the SOGC says. So the SOGC wrote a paper. It's not a guideline. However, we as healthcare professionals are acting as if it's a guideline, and this was specific to inducing women that are 40 and over before they get to 40 weeks of age, gestational age. And then there were some concerns. It says here, I'm really happy that the association wrote this, but they only looked at the studies that the SOGC and the ARCOG were looking at. They weren't looking broader than that. At least what they were dissecting, they didn't look at that. That the absolute risk of stillbirth is low, remains low. That yes, there is an increased risk of stillbirth for like women that have risk factors. But I just read a study this morning that women with lower socioeconomic status have a higher risk of stillbirth than women that are of increased age, but we're inducing the ones that are higher age and not the ones that are that are lower in the socioeconomic scale. So what is coming? Are we going to induce for all these risk factors? Are we not? Are we going to stop looking at what is happening to the individual woman? Which we've already been doing that. So so there's a lot of questions at where this is all going. One of the things that the Ontario midwives wrote was one of the concerns expressed is that stillbirth potentially could be averted. Stillbirth potentially averted by earlier induction of labor in older clients could be offset by an increase of neonatal morbidity and or death. So I'm happy that they are discussing that and they're bringing it up to the midwives, but that's actually not something that I've ever seen discussed in client care. It's actually a client that brought it up to me. This just shows how busy we are and we can't go looking at all this information. Yeah. So the other thing is I do mention that there's an increase in free birth. And I've seen an increase in free birth because of fear of what is going on in the hospitals. And I just want to mention that like intuition is not fear. I'm not here to condone anyone who is free birthing. Free birth is different from home birth. Free birth is someone who does not get medical care and medical or midwifery care and decides to labor on their own without someone there that has experience and the knowledge and equipment to deal with, if there was to be an emergency. Okay, I'm not here to judge these women. This is just something that we're seeing in the population. But there's an increase in free birth, and I don't feel like it's coming from a place where women really want free birth. I feel like it's coming from a place where women are deciding to free birth because they are afraid of the medical system. And that's really concerning and it's not great. And we need to look at that. I have seen some colleagues who are like, well, it's not landing in my hands because they're free birthing. They're doing it over there. Like, I don't need to be concerned with it. That's just like, part of like the medical culture that we are instilling. It's just like, I don't have the time to deal with this. And it's like, this is not the reason why we, went to med school and nursing school or midwifery school. It wasn't to kind of like slug off a part of like what's happening to the population and not care about it. And there's a disconnect there as we are working and all we do is document and all we do is like tell women like, oh, like, I want to like answer all your questions and like, why are you declining this? And those are important discussions, but at a certain point we need to honor the woman's decision, and we need to also not provide information. Like when we are providing information and it's biased and we really prefer to the client to take the intervention, we kind of need to check ourselves a bit, right? And I've done that. I was part of the culture and the system and all of that. Like I'm not going to pretend that I'm this midwife who never did an intervention. It's not me. It's just a part of reality, and we just need to start kind of looking at that. And are we able to provide care for women who make decisions that are different and are maybe not the decisions that we would make for ourselves. Like, for example, can I care? Like, this is just an easier example. There are women who do not want blood transfusion. Would I take a blood transfusion? Yes. But would I reduce the amount of intervention that would lead me to having a hemorrhage? Yes, I would, right? So like, those are things, like, this is an easier example, but we need to kind of check in our biases, and maybe even tell our clients our biases at their first visit, right? So or give examples of biases, because we'll have biases in different things, in different scenarios. I think I want to read this to you guys. Inducing women to prevent small absolute risk based on trials undertaken with very discrete populations neglects these warnings. So like the risks that we are that are increasing for women here, because this is a quote, so it's not part of what I was reading before. Besides, a small increase in absolute risk does not necessarily mean that outcomes will be improved if labor is induced. Without the full picture of longer-term outcomes for single and multiple cumulative interventions and the absence of clear understanding of the compiled morbidity that may eventuate over a woman's lifetime of reproduction, it is not possible to achieve fully informed judgments. That basically sums up everything I'm saying. I was not able to give clear, informed choice discussions to my clients, and I call myself a midwife, where my regulatory body said that I have to give informed choice discussions and I have to honor choice. I was not able to do that. Not able, okay? So I needed to fire myself, basically, because I was not able to do the thing that I set out to do. Okay, so I know that may be like extreme, but honestly, like, I don't have the time to look at all this data and change all of my informed choice discussions while I'm working full time, and while the more I know, the more I have to fight with the system and explain to people what I'm doing, and try to change all these policies and guidelines. I don't even work at these places where they make guidelines, and then like inform women in things that they were not expecting me to inform them on. Like, so like, it just, like, when I'm dealing with more fear and I'm dealing with more fight and I'm dealing, like, I can't do it. So this is just my method. I'm doing it right now. I'm collecting data right now, and I'm putting this information out there, and other people are as well in their own little ways, and hopefully it informs one client or informs one healthcare provider who's like, So when I was a student, I had these really great preceptors, and if it wouldn't be for them, I would never have graduated, because I was a certain kind of student. I was a quiet student. I wouldn't look in people's eyeballs and get, breathe with me. Okay, that's okay if other people do that, but that's just really not my style. And it doesn't work for me, and it exhausts me. And so this is not a way that I can show up at birth. And then I had, like, these preceptors that were okay with that. And then like, I had, like, preceptors, I would, like, tell women, okay, your baby needs to be tested for low sugars and that kind of thing. And then I was, like, trying to explain to the woman why, and then the woman was kind of feeling like she didn't want to, and then my preceptors would put a hand on me and be like, it's not even evidence-based that we are doing these things. So and then all these, and they would explain to me and to the client more. They would take over the informed choice discussions, which was really great. But then it's been years of, like, little droplets of, like, this isn't evidence-based, and this isn't evidence-based, and this isn't evidence-based, and, like, nonstop. And then like I said in the last episode, where we are inducing obese women. Okay, when I started practicing, there was a very, very important thing that we were trying to do. We were trying to mitigate the risks of induction on obese women, because obese women, they don't, their body doesn't respond to the drugs like non-obese women do, and so they have more failed induction. And anyways, that's what I had learned. And so then I was like, we do everything to not induce these women so they can go into spontaneous labor and they can have a good vaginal delivery. Not, I don't mean good, I just mean they have a vaginal delivery where they have less risk, because women who are obese also have the higher risk of infection and not healing well from a C-section. And it's apparent, like, just, you don't even have to look at data, you just, it's in front of you and you see it. And like, that bamboozled my brain, that we were inducing women who I had tried so hard in my practice before to avoid induction for. So, you know, we're seeing outcomes now. We're 2025. We're seeing the outcomes up to 2023 now. We're not seeing I'm going to say it again, we're not seeing a decrease in stillbirth. There is concern about neonatal mortality increasing, and then there's increased risk of morbidity all around. And we're seeing adverse outcomes for women that we really should not be seeing, which is like really terrible to even have to witness the data from. So that's where I'm at. I'm not here to instill fear. I'm here to inform people. I want people to just make decisions, and I want healthcare providers to inform women in a way that is more balanced and well-rounded and truthful and less fear-based. And that's it. So I also want to, you know, if you're a client and you are like, oh my gosh, I'm going to have to argue with my healthcare provider, which is an authority. And, you know, we have a culture where the doctor, the midwife, they're authority figures. And that's it's difficult to argue with them. But I will say that, you know, it's true that sometimes I had a bias in certain things, and I would sometimes be worried about a client if she was to make a certain decisions. That happened very infrequently for me, but it did happen. And there are times too where I'm like, okay, you're deciding not to, you know, give the vitamin K shot, or you're deciding not to be induced until a certain, like a later time than what is considered the policy or the, you know, the cultural norm in, you know, where I'm working and that kind of thing. So you can sign that piece of paper. You can say, I understand the risks. You can repeat the risks that you've understood from your baby catcher. And remember that you have your own spine. This is your birth. This is your body. It's important to understand the risks both ways, or all 17 ways. It's important to do that and to make a decision from that place. But once you understand the risks and you've reviewed those, and your questions are answered, and you're able to make a decision that is intuitively based, not on fear, but just like what feels good for you. I think that I just hope that this podcast and the things that I say in it gives you a strength, and that it's okay to decline things. It's okay to sign a piece of paper. There's no such thing as signing your life away. It's what you are signing is that you understand the risks, that you're making a decision that is against a policy that has been written. Policy is not evidence. Okay, policy is not research. Guidelines are also not necessarily research. They're actually made to look at the culture and what we are doing and the lack of skills, or the skills that we have, like, or maybe not even the lack, but the skills that we do have. It's meant to try to make things more the same everywhere in Canada, not necessarily because there's evidence to do it, but just so that if a midwife goes from one hospital to another hospital, from BC to Ontario, that kind of thing, is just to make it more smoother for her to practice. Okay, which is actually, for me, I hate it, because I actually, we have this big idea, we have this theory. We think that medical doctors and midwives and those people who are providing care are supposed to be really smart. And for me, smart also means that they're able to put different contexts into different scenarios, put together and change their practices, and look at how evidence is changing and continue to change. We don't need to have these things written in black and white so much, and that we're able to use our intuition and our understanding of all the things that are coming in. Black and white is there's a certain point where it's nice to have things in black and white, but at a certain point we need to look at the whole picture, and the picture is the woman in front of us, not the policy. So anyways, it actually reduces my respect for what we are doing if we're not able to look at a whole rounded picture, and if things are made and okay, I have to listen to this in textbook. I don't have a respect as much for people who can't look beyond that kind of thing. And there, I will expand you. There are people who actually see beyond that, and they have practiced long enough. It's not even the people who have practiced long enough. It's people who have a deeper understanding. It's like intuition. They've read through things, and they also question things. They have a natural, they have a healthy skepticism for things. It's important not to go in through this skepticism where we think that everyone is bad. That's not true. I really do believe that most people are good. But I do think that there's a lack of information being distributed. There's, there are certain studies that we put a lot of emphasis on, and then we forget about all the rest. And so that's the culture that we are living in. And so we just need to get together and discuss these things, and not be afraid of informing people of different things, and then they make the decision of what is best for them. There are some of these precautionary reasons that I'm okay, I can kind of understand why you'd want to be induced, and then there's some other ones where I don't understand why you'd want to be induced. That's me. And I have had the time to have experience with women. I have seen things. I have reviewed lots of cases, and I have the time to look at data. So and people who have had the time and the willingness and the capability of doing all these things are very few and far in between. So that's why I am using this podcast as a way of informing, and people get to do and listen to what they want to listen to, and make decisions from the things that they choose to integrate, and the things that they choose to not listen to. I will, so again, I'm going to put lots of things in the show notes, and then in the one where it's about Ontario midwives and what they've summarized for, then in those references, you can go and look at the reasons why we may induce you for certain things. So I know I was here to explain a different lens, but I know that there's a lens where people really want to look at the reasons for induction. So you get to go do that yourself. They're written in the guidelines. Just remember that the guidelines, they're not necessarily written to be evidence-based. They're written to set cultural norms and to make things easier for healthcare providers to be able to care everywhere they go. Okay, so that is my spiel on induction. I hope it was informative. And I hope you have a great, nice rest of your day. And I hope, because it's finally summer, I hope that you get to be outside at some point today. Yeah, have a good day.